There are two major forms of inflammatory bowel disease, Crohn's disease and ulcerative colitis. There is an overlap between the two conditions with similar clinical and to some extent histological features, but Crohn's colitis can affect any part of the gastrointestinal tract, whilst ulcerative colitis affects only the large bowel. Crohn's may involve one small area or multiple areas with a relatively normal bowel in between, although it has a tendency to affect the terminal ileum. Skin rashes such as pyoderma gangrenosum or erythema nodosum should be asked for in the history and looked for in the examination. It is worth noting that smokers are twice as likely to develop Crohn's as non-smokers, so smoking cessation is very important. Endoscopic examination of the affected bowel can reveal deep ulcers and fissures in the mucosa, producing a cobblestone appearance. Fistulas or abscesses may occur. Microscopic examination reveals inflammation extending through all the layers of the bowel. Compare this to ulcerative colitis, where a superficial inflammation is instead seen. Acute attacks require steroids and appropriate supportive treatment such as IV fluids. Those with rectal involvement can be given rectal steroids. Steroid-induced remission can be maintained with immunosuppressant agents such as azathioprine, methotrexate or cyclosporin, and more recently anti-TNF treatment is now an option for refractory Crohn's. Unfortunately, up to 80% of patients with Crohn's will require an operation at some point during the course of their illness. However, surgery should be avoided if at all possible. If surgery is performed, minimal resections are undertaken due to a recurrence rate of up to 15% per year. Indications to consider surgery are failure of medical therapy, complications such as toxic dilatation, obstruction, perforation, abscesses or fistula formation. Due to the transmural inflammation in Crohn's, there is a higher incidence of these complications compared to ulcerative colitis. In ulcerative colitis, the inflammatory disease process is confined to the colon, and therefore colectomy is curative. The incidence of malignancy in both Crohn's and ulcerative colitis is increased, but only marginally so in Crohn's. Those that have had inflammatory bowel disease for more than 10 years will need regular lower GI endoscopies performed for surveillance for colonic malignancy to try and detect early pre-malignant changes.